When you see a patient in the office who has constipation and you suspect that they may have constipation, how to approach that patient? What questions do you want to ask? What boxes do you want to check off? Certainly ask when they had their first bowel movement. Patients with Hirschsprung's disease tend not to pass a stool in the first 24 hours. In fact, 90% of them don't. The fact that they didn't pass a stool doesn't mean that they have Hirschsprung's disease. It just means that you have to raise your suspicion, and you have to remember that that first 24 hours includes the night and the day. So if the kid was born at 10 p.m. and had a stool the next morning at 6 a.m., that's still within the first 24 hours, although a lot of parents misconstrue that unless you clarify. So first bowel movements. How often do they go? What's the size and frequency? This is where your Bristol scale is going to be useful. Do you have pain when you defecate? Do you see blood in the stool? Are there withholding behaviors, sometimes subtle, sometimes not so subtle? Do they soil? And we'll talk a bit about that. And has the child been potty trained? When you see a child in the office who has incontinence, is this a child who was originally trained, who trained at 2 or 3 years of age and then was fine and passed all their poop in the toilet until they were 5 and then started having accidents? That would be a secondary phenomenon. Or is this a primary phenomenon? Is this a 6-year-old who was really never trained for stool? And this has been a long-standing manifestation. We in medicine always look for red flags, those questions or those responses that cause pause and make us think more about them. Do you see an abnormal perianal exam? And I'll show you some pictures in a bit. Is this a kid with fever? Do they have abdominal distension? Do they have anorexia, weight loss, nausea, or any thyroid functions? Do they have a big neck? Do they have cold intolerance and the like? So these are things that push us away more from a functional cause, more towards an organic cause. If you look at constipation in kids, what kind of symptoms can they manifest? Where does that 25% mark in my practice come from? Or 5% to 15% mark in your practice come from? Well, they present with distension, they present with constipation, they present with vomiting. Lots of patients who present with vomiting. You treat their constipation, their vomiting goes away. They have pain, they don't eat well, they have diarrhea, or what we refer to as overflow incontinence, and urinary incontinence, urinary issues. About 30 to 40% of patients with constipation have urinary issues, but only if you ask. If I come to see my patients and I ask questions and I don't say specifically, do you have urinary difficulties? They will not offer that in response. Parents are very good about compartmentalizing their child's symptoms and they don't look at the whole. So you have to ask, but if you bother to ask, about 40% of kids with constipation have urinary tract symptoms, and vice versa. If you're in the VIB clinic and you bother to ask about constipation symptoms, I'm sure a predominance of them do, but you have to ask because they won't offer it otherwise. Why the correlation? Here's a nice anatomic drawing. It shows that basically the pelvis is a shallow salad bowl, fixed space, and that there's a bladder in the front, there's a rectum in the back, and they both fight for space. The bigger the rectum gets, the more it's going to impinge on the bladder. The bigger the bladder gets, the more it's going to impinge on the rectum. And here you see a contrast study showing a fairly big rectum that is distorting the bladder. I'm going to show you next a much more impressive CT scan of a patient that I took care of in conjunction with urologists at Children's Hospital. Here, this is a lateral view. Here you see what can only be described medically as a wicked big rectum full of stool. And this, which reaches from the symphysis up almost to the diaphragm, is a bladder. And this bladder was ginormous and took a while for us to even drain using a catheter. But the rectum in this particular patient was so capacious and really obstructed the urinary outflow. So this is sort of the nth degree of constipation and how it can present as urinary obstructive symptoms. But while startling, this isn't that uncommon a picture, and I've seen a couple of patients in my career who have findings similar. So it's there. If you take patients who have nocturnal enuresis, this is an interesting study. and bother to think about constipation, get a KUB, a predominance of them, of these patients with nocturnal enuresis, really have that as a manifestation of their constipation. And to reinforce what Dr. Estrada said earlier, only 10% of the patient or families report clinical symptoms of constipation in this study, while 80% of the patients who had voiding difficulties responded to management of their constipation. Only 10% really thought they were constipated in the first place. They don't talk about it. They don't make the correlation, and parents don't correlate or track when their school age and older kids are passing stool, or the size or the consistency, so it's easily lost in the shuffle. But another example of how patients can present with constipation, just as an aside, this patient presented to our emergency room with diarrhea. It was only afterwards that we learned about the constipation. Dysfunctional voiding is now a composites term. These are kids who we recognize have both bladder and bowel problems, and a predominance of them will respond to management of their constipation. And you can see the stats here on the right. Constipation resolves, daytime incontinence resolves, nighttime incontinence resolves, and most importantly, recurrent UTIs in these patients often respond very well to management of their constipation. But once again, you have to think, you have to look to make the diagnosis and put the appropriate treatment plan in place. Other clinical history to ask, any evidence of perinatal disease, looking for red flags, any growth disturbance, what's their diet like, is this a carb-crazed kid? I almost never see a patient who isn't a carb-crazed kid anymore. Everybody eats Annie's mac and cheese, nobody eats fruits and vegetables anymore. And everybody's underhydrated. Always good to know past treatments, what worked and what didn't. Were they ever hospitalized? Have they had surgery? Do they have any drug allergies, obviously? And once again, urinary symptoms, because if you don't ask, they won't tell you. Psychological impact, remember how much the quality of life is impaired in these patients. It's impressive how it affects their affect. Kids who have chronic constipation, often withdrawn, often reticent to share. Quality of interactions with either you or their peers, very poor. They start developing lifetime changes. This is why that curve that I showed you gets worse. They're constipated, so they change their life, and they become increasingly unhappy and despondent. Always think about abuse and school performance. The kids are so focused on their constipation, they're so worried about getting out of class that they have difficulties maintaining their grades.